Hey, well, good afternoon, everybody. Hope everybody's doing great out there. I have an exciting interview that I'm doing today. This is with Dr. Erinn Harris James of Harris Internal Medicine. Now, what's going on in the present economy with Obamacare, the repeal with Donald Trump, and all the stuff in the government? It leads people to question what is the next move in the medical industry. And so there's a lot of questions going on. Dr. Erinn Harris James. She'll be talking about her trip to DC and some other things. And we're going to get in depth with her about direct primary care. So this is what this interview is about. Not only is it for other physicians, so if you're a physician that's looking for an alternative of a medical practice, this is something that may interest you. And if you're a patient that doesn't know that much about direct primary care, then this is the place that you want to be. We'll be doing more interviews in the future, of course, talking to Dr. Erinn Harris about the progression of direct primary care in her practice here at Internal Medicine. But for now, I'm going to go ahead and turn it over to her, and we're just going to have a great time with this thing. So good afternoon, Dr. Harris. How are you?
Good afternoon.
Fantastic, fantastic. Okay, so let's jump right into this thing. Please tell us a little bit about yourself. Tell us where you grew up and why did you decide to even become a physician?
Well, I grew up in Indianapolis, Indiana, and I really did not think I would become a physician. I wasn't really geared towards being a physician as a young child. Uh, I thought I was going to be a research scientist. I thought I was going to cure HIV or do biomedical engineering. I was 7 years old saying that I was going to be a biomedical engineer, which is, I know, really kind of dorky for a child, but um, I wanted to, do mechanical hearts or do things like that. So when I entered into college, I realized that I really didn't like the bench science as much as I thought I would. And I decided to give medicine a try. I was talking to a professor about my career choice, and he just asked me, "Have you ever thought about being a physician?" And I said, "No, actually, not really." And from there, I just kind of started pursuing medicine and preparing myself to go to medical school.
Okay, good deal, good deal. So if you can, tell us a little bit about your education, undergrad, medical school residency. Tell me about that experience and how it was going through that.
I mean, it was pretty rigorous. If a lot of people don't understand the whole process of getting into medical school, it's a pretty rigorous process, a very selective admission process. You go through quite a few interviews, and they're very particular about who they admit into medical schools. It's pretty difficult. Some people try, 2 to 3 times to enter into medical school. You have to have high test scores, MCAT scores, and above average GPAs, and show that you're very diverse in your personal life and social life and volunteering and so on and so forth. So, medical school is basically studying for exams and rounding on patients and some social life, because we didn't have as much, we didn't have as much our schedule wasn't as rigorous as our residents. Of course, we were on call and on call overnight, but I mean, it was pretty rigorous. I studied at least 12 hours a day during my first 2 years of medical school, and then my
Wow.
third and fourth years of medical school. Of course, most of that time was spent rounding in the hospital as a medical student.
Okay. Where'd you go to medical school?
Indiana University. I studied Indiana University School of Medicine, and graduated in 1998. And decided to head down south because I grew up in the Midwest and was really just tired of the dreary days, the gray skies and the cold winters. So decided to go ahead and head down south, and interviewed at I decided to go into internal medicine during my medical school training. I had a really awesome professor of medicine who was a great, just a great role model for internal medicine. Actually, two mentors who were great role models for internal medicine. So I decided to pursue internal medicine, and then just interview mainly down in the South. So I would stay warm during the summer. I mean, during the wintertime. And I really was very impressed with Emory University, and picked them as my first and second choice for matching. And they had a primary care program that I was interested in, and in our residency, internal medicine residency program. So I matched with Emory, and moved to Atlanta, of course,
Okay.
and trained with Emory for another 3 years, which was, oh gosh, it was, uh, 48 hours at a time we were on call, and very high patient volume, very critical patients, very um, complicated patients, especially at Emory and Grady. So, yeah.
Wow, good deal. So, okay, so let me follow you from there. So obviously you left Emory and you got
Mhm.
into the working world, and you ended up going, I guess, in traditional practices or traditional businesses of medicine. Can you kind of describe that little journey right there as far as who you worked for?
Well, when I graduated from medical school, I mean, when I graduated from finished residency program, I decided to go back to Indiana. I had to pay back time because they paid for part of my um, medical school tuition. So I served in an underserved area, and I served in a underserved clinic in an underserved area. And in addition to that, came on board as a assistant professor of medicine at Indiana University. So I did academic medicine along with clinic medicine for about 3 years, and decided to come back to Atlanta after enduring the winters again in Atlanta. I mean, in Indiana, and
Mm.
then came back to Atlanta and worked for Piedmont Hospital as a hospitalist. What that means that we only take care of hospital patients. We don't take care of any patients outside of the hospital, not in the outpatient setting. And then decided to go back to the outpatient setting, which I really enjoyed in private practice.
Cool. Good stuff. Good stuff. Okay, so obviously from your experiences there, working for those practices, something made you say, I kind of want to move away from this traditional model of medicine and move slowly toward direct primary care. Tell me, what are some of the issues that you saw in the traditional medical practice that made you even consider a different alternative?
Well, I mean, there was the traditional medical practice. Physicians turn to get burned, tend, especially now, physicians tend to get burned out pretty quickly. We see a large amount of patients in orders, especially if you're in a private practice, it's not connected to a large group like a hospital group. Um, you're expected to see a large amount of patients in a small amount of time. My average um, appointment times were 15-minute slots, but sometimes we would double book those. And, we only had sometimes 5 minutes per patient. Of course, there were complicated patients, internal medicine, and then the paperwork associated with that, with prior authorization forms for medicines, and when insurance company didn't cover something, you actually would have to call and make sure it was covered, and of course all of the um, just the paperwork that was associated with that, refilling medications, and just everything. It was is and you just had such a large patient base to take care of at that time to do all that for. So it became really tedious. I kind of just tired. You just became really, really tired and burned out, and wonder if you were making a difference. There was sometimes I would go home and wonder if I did the right thing for the patient, because I didn't have enough time to spend and didn't have enough time to kind of figure everything out, look at everything, and it was kind of just on to the next patient to take care of them. And so, we would have a patient base of 2,000 to 3,000 patients at a time, and it was. I think a lot of doctors are having a difficult time trying to keep up with all of the details with electronic medical record system, making sure that we submit the right detail on our notes, and paying more attention to submitting the right thing on our notes, and clicking all the right things in order to get paid by insurance companies, rather than paying attention to to paying attention to the patient.
Wow, wow.
Direct primary care is totally different from that. So.
Okay, okay. I'm definitely sure there's hundreds and hundreds of physicians out there that feel the same way or going through the same thing. So obviously, this is a reason why in our political climate that doctors, physicians, insurance companies are all trying to find something different because of the demands of healthcare are rising. So with that being said, tell me exactly what is direct primary care, and why do you feel that that's kind of a better model that kind of fits this day and time?
Direct primary care, just to simplify it, the most simple terms, is just a direct relationship between the patient and doctor, minus the insurance company. So a lot of people think of direct primary care as a concierge model or a boutique model, which really isn't the case. Direct primary care, basically, the doctor contracts with the patient instead of the insurance company. In traditional models or fee-for-service models, a doctor or a doctor's office would actually contract with the insurance company to pay for the office visit, or any anything that we would charge a patient. Instead of the patient contracting with that patient, we contract with the insurance companies, Medicare, Medicaid, Humana, United Healthcare. And we would have a contract that would say, for a specific patient or for a amount of patients, we will pay you this much for office visit. We will pay you this much for this or this particular procedure. We would pay you this much for, giving a person a nebulizer. We pay, nebulizer treatment, or so it was so much that the insurance company would, contract with the doctor or the doctor's office to pay for the patient. Now, the reason why this is different in direct primary care is we take that whole middleman or insurance company out of the equation, and we put the doctor and patient back together. And so the doctor just contracts with the patient alone in order to pay for services, in order to pay for office visits. And it lowers, of course, the amount that the patient has to pay, because a lot of patients, well, I don't pay, that much everybody's paying for insurance in some type of way or form, even if you're on Obamacare and you have a subsidy there, which is why what we're paying for insurance is astronomical, and the premiums are astronomical, because you're paying for health insurance regardless, whether you realize it or not. So that's why it's more affordable when we contract with patients that way, and it's more intimate, because now our patients are our customer, and not the insurance company are our customers. The other way, fee for service, during in the traditional model, whether we liked it or not, the insurance company was our customer, because we had to check off the box and make sure the claim was correct in order to get paid from them, to please them in a sense. And now we're back to where it should be, is the patient is our customer. The patient is who we focus on. Our patient is who we determine whether we're doing a good job or not doing a good job.
Exactly. Good stuff. So if you can elaborate a little, now, what exactly is the difference between a direct primary care practice and a concierge practice?
Usually, a direct primary care practice contracts directly with the patient to cover office visits. So you will pay a monthly membership fee to pay for service. And so usually nationally, the monthly membership fees average between $50 to $70 a month, up to $90 a month per month for a patient. And most of them are based upon your age. A concierge practice, you still have the insurance involved, and so they still charge the insurance company for your office visit or your anything that's done in the office, anything that that the office will get paid for the patient. But and on top of that, on top of the insurance, they also charge a fee for improved services such as longer time spent with the physician or less wait times, home visits, things like that, that are actually already included in most direct primary care practices.
Okay, okay. Thanks for elaborating that. Now, as I understand, you're one of the few doctors, especially here in the Southeast, that actually started your direct primary care practice from the ground up. I see this common practice for people to flip a practice. So if you can, just go in a little bit as far as uh, how difficult was it to start from the ground up as a practice, which some physicians may consider doing that if they're getting out of school, or maybe they're leaving a big network and going out on their own. And then also maybe explain what maybe the advantages or disadvantages there is of flipping a practice. And then if you could go over just really what was the cost of getting that started from the ground up.
Okay. Well, also, I just want to make sure that everybody understands kind of like what direct primary care entails, in addition to not being, taking the insurance factor out of it. Most of direct primary care offices offer um, what I would like to say enhanced services. Most fee-for-service offices, you're not going to get an appointment in appointment in 1 to 2 days. Usually, when you call most direct primary care offices, your appointments are 1 to 2 days away. You can get an appointment next day or same day, and also you have extended time during your visits. So your visits are at least 30 minutes or more. My visits are at least an hour for my first patients. I mean, for my new patients, and my return patients at least 30 minutes. And also we have increased access, which is another big, that's another big, what is the word I'm trying to use? That's another big feature, I would say, of direct primary care is we directly contract the patient, and plus we have more access. So it's no longer you can't talk to the doctor when you call the doctor. You actually can speak directly to the doctor when you call the office. And so in addition to a lot of other things. So when I decided to start my practice, I had decided to go to the VA to try to figure out my life after I got burned out in private practice. And so I had lost contact with patients because, of course, when we're in your private practice, a lot of people have a what is it called? What am I thinking of? When you can't, you have a non-compete. Thank you.
Okay.
So I had a non-compete, and I decided just to, ride the time limit of my non-compete out. And I couldn't, of course, solicit my own patients, so I started from the ground up. They knew I was out there, but of course, when I started, it was, I started in May of 2014. So there weren't a lot of direct primary care practices nationally. Well, I found out there was nationally probably about 160 practices in direct primary care. And so there wasn't a lot of information out there. And then the public didn't know a lot about direct primary care. And so when I would tell them, they were like, "Oh, Dr. Harris, you're back in practice. Let's, let me give you my insurance." And I would always say, "I don't take insurance." And they were like, "Are you sure? You possibly, when are you going to take it?" And I'm like, "I'm not." And I also had physicians who were my colleagues who knew me from practicing in the area. "Oh, when you should take insurance, you shouldn't do that." And that was back at the time, was pretty unheard of, when everything wasn't getting drastically worse. Back at that time, it was getting bad, but not as bad as it is now in healthcare and for practicing physicians, of course. So starting from zero was very difficult because I had to do a lot of networking. I had to do a lot of marketing of myself and educating people about direct primary care and what's, what it's all about. And really, and not only just educating the public and not only educating my patients, but educating other physicians that, no, I'm not crazy. No, I didn't get in trouble with my license and that's why I'm doing this. No, I really think this is a better way to practice. And if you can, and so even now when I talk to some patients, oh, you're doing boutique medicine. Oh, you're doing concierge. No, direct primary care is different. It's affordable. It works. It, it helps people,
Right, right, exactly.
And so yeah, it was kind of getting traction was difficult. I had to, of course, which a lot of direct primary care doctors do, is I had to work, you know, part-time. I had to do moonlighting, which just means besides, doing your practice,
Mm.
you also have to, you do part-time work in order to support the practice. But the main thing was just educating people, getting the word out. And people thought it was a good idea, but they still didn't get the concept. So being kind of new in the area and knew just the first person to do this on the south side of town, well, it was pretty difficult. So south of Atlanta, it was pretty difficult.
I bet, I bet. Okay. So with that being said, and one of my other questions is, what's an average ballpark area of starting a direct primary care practice from the ground up?
As far as like cost,
Costs, I mean, as far as, getting your facility together, maybe putting your back office, front office together, things of that nature.
well, I tell if you're starting from zero, I would start what's called a micro practice. I wouldn't spend a lot of money doing a lot of cutesy things in your office and making it state of the art, or have everything new, because you're going to spend a lot of money and you're still going to have, even though your overhead will be lower, it would be much lower if you would do more cost effective things. So I said our average ballpark, you should spend no more than $15,000 to start up your practice. And what I did, I was very fortunate to have um, rent a space that had a low cost per square foot, and is still in a place where I can grow if I decided to add on more physicians to the practice. And I wouldn't have to move, I wouldn't have to move the practice and people try to find me or figure that out. So also I bought a lot of secondhand, used furniture. I bought
Mm.
used medical equipment. I found a person who would sell medical equipment wholesale. She would get it from hospitals and closing practices, and she would sell office furniture and front office furniture and waiting room furniture for wholesale. And so I saved a lot doing that by buying, used furniture, and just shopped around for the best buys for, EKG equipment or that type of thing. And then just, there were some mistakes that I did make. I paid sometimes too much for professional help, like legal help, where I didn't realize what was out there as far as available to me for legal help. But as you grow, in your practice, and as you grow in business, you learn to, you know, kind of deal with the mistakes that you made and make better decisions. But I would say to no more than $15,000
Okay.
to start your practice.
Good stuff. So, as you're saying, there was a learning curve that you had to experience starting off your practice. Even though you've been in practice for several years and worked in a traditional model, that first year or so, I guess you'd say, was kind of a big learning curve for you.
Oh yeah. Not only, was it uh, me being a physician I was trained as a physician, and I didn't have an MBA, so I didn't know much about um, running a business. And so most of my learning curve was actually just learning the learning how to run a medical practice in itself and learning how to run a business. I knew from being in private practice and being in practices how to actually, how the workflow should go and everything should go. And, but this just, learning how to run a business is a big learning curve for you. And also you had a new model that you're working with. You didn't have the old fee for service model. So you just couldn't bring in somebody who would submit claims and have an office manager that knew how to do traditional medical practice. You're dealing with memberships. And so how do you process memberships and what platform do you use? And do I do it on QuickBooks? Do I, do I do it, do I just get a check every month? Do they pay me cash? How do, and so there wasn't, an EMR service, not like electronic medical record service that could just have your practice added to it to, like the practice platform or the practice software to manage your practice along with it is, it wasn't until I think a year or 6 months to a year into me starting my practice, there was a membership like software platform that actually processes your memberships and does it very efficiently. Before it's called Hint Health, and beforehand I was like, well, what's out there? How do you do it? And I was basically doing it just invoicing my patients through QuickBooks. So.
Okay. So that's the great thing that I'm learning. And I'm speaking to everybody that's out there also. What you're saying is that you didn't have a roadmap for something that was such a new industry that was coming about, or at least a new business model. And so you kind of had to figure it out. That's what the learning curve was there. And so at this point, I know you're still growing in the business, you're still going, but what I always recommend is, guys, listen to this video and take the tips and suggestions that Dr. Harris is talking about here, because there's two ways that you can learn to grow a practice. You can either do that by keep bumping your head against the wall, making continuous mistakes. You will become successful eventually, or you can learn from the mistakes of others. And so that's why we put this video together, so that people that are looking at the direct primary care model can start to kind of have a roadmap to go after, and actually look at Dr. Harris and other successful physicians that are growing in your area on how to do this thing. So let me move on with that, because now I want to dig deeper, because we talked about all the good stuff on the top. I want to go dig deeper so that we can really help some people out there. So if you could start all over again, what would you have done differently when starting your primary care practice? What would you have done differently?
Oh, I probably wouldn't have spent as much money on legal help, my attorney. And I probably would have not, I wouldn't have chosen some associations I chosen. And I probably would have reached out to other physicians who were practicing more often. I knew of 2 physicians who were practicing in North Georgia and East Georgia, but I probably would have reached out to them more often to see, to form a community more, just a little bit earlier, to kind of get a handle on, are you doing this, or well, how do you do this, and what are you doing for this? And I did, but I probably, did it once or twice, and I would have been more of a nuisance to them rather than just say, oh, okay, well, I talked to them once, and and I would have probably, forged a better relationship with them. Not saying that there is not a good relationship now, but it's just, I would have probably been in contact with them more often.
Understandable. So to piggyback off that, so tell me, what are some of your small and maybe big mistakes that you encountered while growing your practice, and what would you recommend others that are on this video here to looking at, wanting to maybe look into a DPC practice, maybe wanting to start? What are some things that you would recommend to others that want to start, to pay special attention to?
I would say pay special attention to how you're going to process your membership. That should be very tight. That should be a very tight way of doing things, especially if you're just like for me, I'm a micro practice, so I don't have anyone helping me. And so I really needed to figure out a very efficient way to handle my practice. And so um, I have my husband who helped me. Um, to help me figure out a really efficient way to do my practice. Like if someone calls and you're not in the office, because a lot of times you're really flexible in a micro practice, how are you going to get calls to you on uh, all the time? How are you going to be able to pick up 24 hours a day? And I had to figure that out. Well, there are products out there. We're a very technical technically advanced society, which we can be able to answer calls from our office, 24/7, and also make sure everything is in place in order to be able to support what you're offering. So if you're offering, access, you need to be able to have something in place to offer access. If you're offering efficiency, you need to have something in place to offer efficiency and to be able to do things with ease. You're not trying to make anything difficult in direct primary care. We're all about making things easy and simple. And so making sure those are things that you have in place to, if they need to sign up online, do you have a way to get people to sign up online? And if they want to text you or video you, do you have something in place for that? Another big thing in direct primary care is medications. Do you know how to process your medications that are on site? If you dispense medications in your office to provide as something for your patients to take advantage of, do you have a way to have that process in place, and does it work where you've gotten a lot of the kinks out? And so I know for my first year, that's what I got a lot of the kinks out. Okay, if someone came in, I always thought to myself, if I had 15 people to sign up in one day, will I be able to handle that load, and how will I be able to do that efficiently? And so I think those are the main things you need to kind of think about when you're starting.
Okay. So what you're saying is that you kind of had to find a system that works for you, that your business is kind of built on efficient systems, especially for a 1 or 2 man show, basically is what you're saying.
Yes.
Fantastic. So also now you've discussed in the past another piece to the direct primary care, and that's with the prescriptions as far as that. And can you kind of just touch a bit on that as far as prescriptions to provide for your patients also at the wholesale, I think you talked about.
Yeah, I mean, when you're in direct primary care, you're offering people a membership. They also have to see is this valuable? Is this membership valuable for me? And one of the things that we call, especially in direct, when we say it adds value to the membership, it means that we're offering services that people think, okay, when I'm paying, my monthly membership fee, I feel like because I pay this every month, this is the value that it adds to my life. I can be able to access the doctor, I can get there when I need to. I don't have to wait 3 weeks. The other thing is if I need a medication that that I say the doctor wants to prescribe me a medication, I don't have to go to the pharmacy and waste time. We're all about not wasting time in this day and age. And so I can get it right there. I don't have to go anywhere else. I can get it right there. And it's provided at a low cost. So I need to also be competitive with the pharmacy prices. The pharmaceutical markup is ridiculous. The markup for medications is quite ridiculous. And so we add value by saying, okay, we can provide this medication for, at cost, which is usually a lot lower than, unless it's free, that you can get from Publix or, another $4 medication from Target. But usually we can offer it lower than, your generic prescription costs, or of course, lower than what you can get in a pharmacy, a retail pharmacy, and the convenience of getting it right here at the office.
Oh, wow, that's incredible service, and that's good. I mean, I know my experience going to a traditional doctor. I've had to wait for an hour after I had an appointment, and I showed up on time. I had to wait an additional hour, 45 minutes out of my workday just to go see the doctor. Then when I finally go see my doctor, I'm only in there for about 15 minutes, and they're shuffling me out the door. Then they give me my prescription. I got to go and go over to whatever CVS, wherever, and probably wait another 4 or 5 hours if they can't get it quickly just to get my medication. So it sounds like everything is really simple, really efficient, and I get to have that time with the doctor. And so that's where I guess direct primary care is more of an advantage from the customer side of seeing that, and being able to really talk to my doctor and not feel rushed and pushed out the door, and then not having to wait 3 months for an appointment. So
Yes.
that sounds like some really good stuff there. So Dr. Harris, recently you went ahead and took a trip.
Actually, to add to that,
Oh yeah, please go ahead.
actually add to that, we also do, most of the direct primary care offices actually do labs in the office, which are offered at the wholesale price too. And so I've had some patients tell me, they've had the same lab done and they paid $300 out of pocket for the lab, and I'm charging them $3 for the lab. And
Wow,
so,
incredible.
yeah, or they had to pay, you know, a lot of times I say, well, you can just get your labs here, and they're like, oh, well, well, how much? Well, how much is it? Because you know, their thing is, oh, I'm going to say, oh, it's going to be $100, and then when I tell them, oh, it'll be about 15 for everything, and they're looking at me like, you're kidding, and then they're saying, well, why is it so much everywhere else? And so I think that's one of the benefits and values that we also add to direct primary care. So,
Excellent, excellent. And guys, I'm going to go a little further in the interview here as far as how the direct primary care practice really makes money to have an income. So we'll talk about that in a minute. But what I was going to get into is that you recently took a trip to Washington, D.C.
yeah.
And not only are you an involved doctor in your community, but you also have an interest in enhancing the political side of direct primary care and getting involved as far as the legislation and the lobbying aspect of it. If you can, please tell our viewers what you experienced there. What was the goal of going to Washington, D.C., and who did you speak to, and what happened? And from there, we'll kind of go into the medical industry and where you see the future of DPC going from there.
Well, we all gather together. A there's an annual direct primary care conference, which I was very fortunate to attend this year. And we decided to gather in DC because of the upcoming legislation to push for healthcare reform. And one of the bills that were on the table are were was a bill to make sure that direct primary care is not considered as an insurance product. Right now, the IRS considers direct primary care and insurance one and the same, and so you can't use. Although the actual government doesn't see direct primary care as insurance, the IRS does. And so you are not able to use your direct primary care membership with a health savings account at this time. Now, you can't use them together, so you can't use say if you have a health savings account with a high deductible health insurance plan, you can't put money in that health savings account to pay for your membership. And we want to change that, where you are able to do just that, use your health savings account to pay for your direct primary care membership. And so what that does is open a lot up. It's just not just for that, but it opens a lot up to maybe couple it with Medicare and couple it with other insurance products. And so that's why, we were pushing for that legislation. So and I also, I met with my state the congressman for my state, or for my district, and he was awesome, and really, he's a former dentist, so he really understood the concept, and of course, there were senators there who were former physicians who were really pushing the bill, and so it's something that Democrats and Republicans agree upon as far as like pushing direct primary care because of the access, because of the availability that we have for care, because of the fact that we are really big advocates for our patients and making sure that they stay healthy and stay out of the hospital, stay out of the ER, because they have the availability, they have the ability to come to us instead. And so it was just a really good experience. And so on the back end, I'm really pushing to make sure that that same legislation there is that legislation to make sure that direct primary care is not insurance, is not necessarily in place in Georgia. And I'm really want to form a group in order to make sure that we push that legislation through. I'm in Georgia. It's actually been pushed in other states, from Michigan, Louisiana, and other states around the country. Several states around the country, but not here in Georgia yet. So.
Okay. So obviously it's growing.
Mhm.
It's becoming more prevalent here in the marketplace as an alternative to other forms of self-pay and things of that nature. So where do you see the future going? Now that you had an inside peek from the legislative side, from the market side, where do you see direct primary care going over the next 5, 10, 20 years?
I think it would be a viable option for doctors, first of all, who have decided not to join larger groups, um, to be able to still keep their doors open, and practice medicine the way they intended to practice medicine, which is to have a relationship with their patient. And also, I think it's going to grow. It's going to continue to grow. We've grown from approximately 160 practices back in 2013, 2014, to now in 2017, over 600 practices
Wow.
nationwide. And so I think that with momentum, we will continue to grow in that. Also, I think that with patients understanding that there's a different choice out there, I think the direct primary care will grow because of more people wanting direct primary care. And they are, that's a consumer the consumer wants this product. And so I think it will grow from that aspect too. And I think you would start to see more direct primary care um, offices or practices kind of be a office being inserted into insurance product, where they'll still be able to keep their autonomy as a physician in practice, but still have a product where you have your direct primary care doctor and still able to cover your hospital and surgeries and some higher medications at a lower cost, and still bundled all in one insurance product.
Incredible. So, Dr. Harris, explain to me now. It's not now you're an internal medicine internist, as they call it, I guess. And so, does direct primary care model, does that model work in other areas of medicine? What are some other examples where that model could possibly, I guess, work in the medical field?
It works as, when you say direct primary care, you don't necessarily have to just do monthly memberships. You can also do um, cash per visit. So you can work on a cash basis. And you see other models that do that, like surgery. There's a surgery center in Oklahoma, I think, that does cash, and it charges much less than any other. Um, you can get a surgery for much less than you would get it if you pay out of pocket for it in a surgical center at a hospital. And also, I've seen an orthopedic physician do it here in Georgia, in North Georgia. It can work for any other specialty. Of course, all your primary care practices, pediatrics, family medicine, which is most popular, in internal medicine, but also OBGYN. It could work with that practice. Also, any specialties, neurology. So the model could pretty much work for any specialty. It's just with each specialty, there's a difference in how you would have to work with, like if it's a surgical specialty, you would have to work with a surgical center, or or for radiology, it would have to be your own kind of private radiology practice. So yeah, it's workable for just about any practice. So.
All right, good stuff. So, okay, so let's kind of get now. We're going to kind of shift over here to the life aspect of being a direct primary care business owner. Okay, so you're a mom, you're a spouse, you have children. You're involved in your church. You do volunteer stuff. You're just involved. You're flying to Washington, dealing with political things. So you wear a lot of hats doing this thing. So I guess, and then you're running a practice solo right now, and you're growing this practice. So the big question is that everybody has, even from a 9-to-5 standpoint, is how do you balance family, work, and your personal life while running a direct primary care practice when you're doing telemedicine and when you're booking appointments and things of that nature? If you can get into that.
Well, one great thing about direct primary care is it's very flexible, especially a micro practice. Is very flexible, so you're able to have a lot of work-life balance with direct primary care, and so it affords you time where if you see on your schedule that, I have some time where I don't have any patient schedule, and plus my schedule, on average, a full direct primary care practice, which is about 400 to 500 patients. That's the maximum amount most direct primary care practices will take. A full practice, you see on average about no more than 10 to 12 patients a day. So if I look at my schedule, I have a good 2-hour block. I go to the grocery store, or I manage other things. And if I'm out of the office, then of course I'm carrying my cell phone with me, where my office call will go directly to my cell phone and I can pick up as if I'm still in the office. So it allows me to do other things. I still, of course, work part-time and doing part-time work to subsidize the income. And, it's just a lot of planning. As a businesswoman, you have to learn how to plan your business, and you of course have to take that home with you too, and plan very well and stick to your plan.
Absolutely. Good advice. Good advice right there. So, all right. So you just touched on something that I know a lot of people have a question about is you said a full panel. One, if you can define what a panel is, and then you said the average number may be between 400 to 500 people that are in your panel. So with equating for that, what is the income potential that a business owner like yourself may range from having a micro practice? If you can kind of dive into that a little bit also.
Well, again, a full panel of patients means that this is the amount of patients that you will see in your practice, or this is the amount of members that you would take on at one time. Like you said, most fee-for-service traditional practice or fee-for-service, their patient panels between 2,000 to 3,000 patients. We narrow that down to 400 to 500 patients, or more than 1,000. And of course, that's the way we can offer longer visit times, less time waiting in the waiting room, because your appointment starts on time, ends on time. There's not a lot of double booking. People get their 30-minute appointments in and their 1-hour appointments in. And so if you say that, okay, my goal is to have 500 patients at one time, or my goal this year, if you're basing your budget out how you're going to budget and pay for bills or whatever, I'm going to have 100 patients by the end of this year. I take the lowest amount that I charge every month, which is $50 for my employees, or employers, $50 per employee. And I say, okay, I'll take $50 per person per month, and that's how much, you know, um, that would be my income. It's very, I mean, it's really, really pretty easy. And so anything above and beyond that, I take as, you know, profit or excess, you know, excess. I don't count on anything coming in except for the $50 per month. And some people may do it differently, but I try to work as lean as possible. So through that $50 per month per patient, say if I had 100 patients, you know, what is that? Let me do. I don't. Can you do the math for me?
That's gonna be $5,000, 50.
Yeah, so that's, yeah, $5,000, $5,000 a month.
Yeah.
And which, you know, you take $5,000 a month, um, and you add that up over a year, you can say, okay, minus my overhead, that's how much my income would be. And you can base yourself, okay, if you're going to see, if you have $400 patients, then of course that's, you know, 50 times 400,
Mm-hmm.
which that would be less your overhead, which is usually not very high. My overhead is between, you know, without an employee, my overhead ranges between like 3,000 to maybe 3,500.
That's really good.
Yeah,
That's really
dollars.
affordable right there.
Yeah, so my overhead is about $3,000 and which is pretty typical of a direct primary care practice. With an employee, of course, that would probably go up to about $4,000 to 500. I mean, $4,000 to $5,000 a month. And so we tell people, if you're a micro practice, don't bring on an employee until you get to about 200 patients. And of course, you can see if your base of you're charging, you're saying, okay, I know if I have 200 patients and I'm going to charge at least $50 a month per patient, then I know this is, you know, how much income and this is how much I can be able to bring on an employee with. So it really, would I say you're going to be a billionaire or a millionaire? No, but you're probably going to live just above where you were when you were practicing medicine in a, you know, when you were an employee or if you had your own practice. And the one great thing about membership medicine is it's pretty predictable. So you know if you have this many patients, you're going to get this amount of money every month. It's not
Absolutely.
based on filling your schedule up and I have to see so many patients per day. It's based on, well, I know I have this many memberships, so I can budget accordingly, or I can, you know, plan accordingly based on how much I, you know, am going to bring in every month.
Okay.
It's not haphazard. It's very predictable.
Absolutely. I mean, the numbers are pretty simple, so that's pretty good. So, okay, you
And
brought up.
I need also to add, and of course, you're not putting all your eggs in one basket. So if you lose a patient, or a patient decides to move, or a patient decides to, you know, they say, oh, I want to, you know, get on my husband's insurance, or oh, I, you know, decided to leave the practice. You're losing $50 a month. You're not losing, you know, $1,000 a month. You're not putting a dent into your budget when that happens. So.
Good stuff there. So, okay, so let's say somebody that's checking this interview out says, you know what, I want to go ahead and start a micro practice. They listen to what you said. They spend about maybe $15,000, and they're growing. Maybe they're starting from the ground up. Maybe they may have a small practice that they're kind of flipping over. So tell me what has worked as far as marketing and what doesn't work, because there's a lot of ideas out there that people should throw all this money into marketing. And now that you've gone through the trenches for the last couple years or so, you've kind of had a timeline to see what works and what doesn't work. What are your recommendations for that?
I wouldn't recommend any postal mailings. I wouldn't recommend newspaper ads. I would not recommend spend a lot of money on try to do TV ads or magazine ads or anything like that, because direct primary care is very people have to understand the concept, because it's still is still in the beginning stage. It's not like a very recognizable product like McDonald's, where you can just advertise and people understand when they see, you know, McDonald's, they know that you're going to get burgers and blah, 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 blah. But with direct primary care, they're still kind of scratching their head. Now, what is that again? And how does that work? And so, honestly, I would spend most of your time and effort on networking. So network to get to meet other small business owners, other people in the community, um, and join your chamber of commerce, join other small networking groups in the area, get to know people in the area, so you can explain the concept. When you just meet them one-on-one, they ask what you do or they ask what your business is, and then you give them your 1-minute spiel, and then you kind of spark their interest about, especially when I was early on, people, it was just it was foreign and people didn't had never heard it before. And then from then I can form relationships with them. Hey, you know what? I can come to your office, or I can come to your business, or I can sit down with you and we can meet for coffee, and I can explain a little bit more about how direct primary care works. I can bring donuts if you want me to. And or I found that the educational time that I spent either one-on-one or within a small to medium group really worked well, rather than just putting something out on a postcard and people just throw it away and you wasted a lot of your money. So I've heard radio spots tend to work really well too, but the tried and true is networking, and educational forums and word of mouth. Word of mouth. By more than anything, by all means, word of mouth.
Good deal. Now, as I understand, not only do you market and grow your practice with individuals, but you also talk to corporations also. Can you touch on that just briefly, as far as what are some of the advantages to speaking to small businesses? What are the size of the small business that you're targeting? And what are the benefits to that small business? Why should they leave their provider and look at a direct primary care practice as a way to benefit their employees?
Well, the thing, I usually target small businesses that have about 2 to 3, no more than 20 employees. 50 employees, that's great. But I target your small mom and pop operations, realtors, insurance agents, things that where they are not able to afford those high premiums anymore to cover their employees, but they still are looking for a benefit that's reasonable to provide, you know, at least some type of health benefit for their employees. And so when I give them a price of $50 per month per employee, they were like, "Sign me up, working." What
Absolutely.
can I do to, and what it does is it doesn't necessarily, and they even say, okay, well, some of my employees can pay half for this. If they decide to sign on with you, they can pay half and I can pay half. And so it becomes a win-win situation for the employee, because maybe the employee says, I want to stay with my own doctor, but hey, some employees are like, hey, I'll go to a doctor if I don't have to pay anything every time I go to her office. I don't have to pay a copay. I don't have to, and I can get, the benefits of, saving money for them and their family. I'll go for that. And also the benefit is, you get the time off from work. A lot of people get sick and you don't want to go to work sick, but they end up going to work sick because they can't either get time in to see the doctor because the appointment times are so far off, or they don't fit their schedule. So we offer to, if you just need to talk to us on the phone and you need to come in later, or we provide flexibility with the employers and the employers' schedules, and so it's less time off from work. You're not taking all this time off to recover, and because you couldn't get in to see a doctor or something.
Okay. So with that, just to kind of expound on that just a little bit more, with direct primary care membership, is that now in lieu of the Obamacare Act that's going on, and does that alleviate small business from the penalties of it now? I know there's some legality stuff there. If you can kind of touch a little bit on that.
Well, of course, businesses under 50 I think it's pretty much 50 or not necessarily have that penalty, um, of, but they still think it's an added benefit, which is why it really appeals to them. But of course, if you're an individual and say you don't, some people just decide I'm going to take the penalty and just go to direct primary care practice and not get with Obamacare. But however, some people, if you do go to a direct primary care practice and you do have um, you know, a, an insurance product through the ACA or the, Affordable Care Act, it does qualify under the Affordable Care Act being for not being penalized for not having insurance. So, um, but with um, but with businesses over 50 members, there are insurance products out there. What I've learned about that actually plug us into the insurance product instead of having a primary care component of it, they kind of plug direct primary care into that product.
Okay.
To provide a more insurable, a more affordable health plan for their employees.
Okay. Well, cool. Well, Dr. Harris, we're going to start to kind of bring it down a little bit. My next to last question is, where do you see yourself and where do you see your practice going in the next year or so in that direction of direct primary care?
Where I kind of envision myself is just really one of the main thing is being a really continue to just be an advocate for my patients, first of all, and also be an affordable, just being an affordable option for especially employers who are really, if things don't change pretty soon, if they continue just to go the way they're going, and they put their hands up, they don't know what to do, and just to be an affordable option for employers, to kind of give small businesses a break, because I'm a small business, and I also want to allow that same break for other small businesses, and to also start to push more education. So I see myself as pushing more education on the state and national level for direct primary care and for direct primary care legislation. So that's kind of where I see myself moving forward. Just forming a nice, big, happy direct primary care group.
Absolutely, absolutely. Last thing, Dr. Harris, where do you recommend people to go to learn more about direct primary care, and how can people reach you to get more information about direct primary care and starting a practice, maybe running a practice, and knowing more about the industry?
Well, if you want to know more about my practice, you can either call me at 770-954-5010, or you can log on to my website at www.harrisinternalmed.com. That's harrisinternalmed.com. And also, if you would like to know more about the direct primary care movement in general, there are several websites. There's a DPC Frontier. .com. There's also I Want Direct Primary Care .com, and there's other ones that I can't remember just off. But if you log onto my Facebook page, I have a lot of information on where to find that out. And there's also explainer videos where you can find out more information about direct primary care.
Fantastic. Dr. Harris, we really do appreciate you taking time out to do this interview with us. Guys, understand that direct primary care is an emerging industry, and it is coming. It's growing by leaps and bounds. Dr. Harris is one of the growing people that's here in the greater Atlanta area, located down in Tyrone, Georgia. So we're south of the airport here. So, jump on the website, harrisinternalmed.com. Give her a call. She's more than open to sharing some information. But not only that, we want everybody to understand and get to know what this direct primary care model is all about and why you see so many doctors starting to go toward this model. So I'm going to have the information down below so you guys will be able to see that. And, with that being said, Dr. Harris, we really do appreciate you. Thank you so much. Any last words to tell the people out there?
No, mainly that we're open. Mainly, any direct primary care practice should be open to any of your questions. So if you have any questions, just let us know. We'll answer your questions for you.
Fantastic. Thank you, and have a great afternoon. Bye, everybody.
Bye.